development. And a distinguished lecture series such as this offers us, ladies and gentlemen, to hear leading and cutting-edge research in medicine, to hear the best from clinicians, to hear the best from the best tutors in the world. This annual Distinguished Lecture Series is actually named after Professor Eric Cruickshank, and that's in honor of his innovation, leadership, and commitment to academic excellence and research. Eric Cruickshank was born in 1914 in Dumfries, Scotland, and he died in 2007. He was educated at Aberdeen Grayham Grammar School and the University of Aberdeen. He graduated MB CHB Honours in 1937 and MD Honours and Gold Medal in 1948. He was a fellow at Harvard and Massachusetts General Hospital between 1938 and 1939 before returning to Aberdeen as lecturer and then senior lecturer in the Department of Medicine. He was also an NHS honorary consultant in Aberdeen from 1948 to 1950. So this leading gentleman, this young academic, moved to Jamaica to take up an appointment as Professor of Medicine at the then University College of the West Indies at Mona. He was in fact the first Professor of Medicine in the University College of the West Indies in 1949. And while he was here, he published extensively on nutrition, neurology, and medical education. But one of his first publications was on Jamaican neuropathy. Did you all know this? He laid the foundation for the seminal work on its etiology by one of his students, Professor Rogers Johnson, and of course this was followed up by Professor Owen Morgan, and we now know the etiology of this disorder, that is an HLV1 associated disorder. Professor Cruickshank left Jamaica in 1972 for Glasgow, and in 1961 he was awarded an OBE in 1961. We were very, very privileged to have this professor as our first professor of medicine at the then University College of West Indies. And at that time, there were only a few medical students. Today, as you know, we've graduated over 7,000 doctors, and we have at Mona over 1,100 medical students in our MBBS program. As the dean will tell you, we recently had a 93% success rate in our MBBS exams. Can I have a round of applause for that, please? Thank you very much. And we had the highest number of honors in all of the 3 campuses. So we know that we at Mona can teach. A round of applause for the teachers in the audience, please. But we also want to know, we want to do meaningful research, we want to change the lives of our patients, and today we have one person who we can emulate, one success story. And that, of course, is Professor Grayham Sargent. Professor Grayham Sargent is one of the leading, worldwide, internationally known experts in sickle cell disease, and his work has improved the lives of persons with sickle cell disease all over the world, and it has changed policy, health policy all over the world. So we are very, very pleased to have you here, to be with us as we hear from this very distinguished gentleman, and we will hear more about him when we introduce him. A round of applause, please, for our distinguished lecturer. So once again, welcome, and I hope you enjoy what will happen from now. Thank you very much.
Thank you very much, Prof, for that welcome, as well as informing us about the history behind Professor Eric Cruickshank. At this point in time, I'd like to welcome the Dean of the Faculty of Medical Sciences, Dr. Tomlin Paul, to come and give the greetings.
Thank you very much, Dr. Hosang, our chair. Professor Rosemary Wright Pascoe-Williams, head of the Department of Medicine. Professor Graham Sargent, our distinguished Eric Cruickshank lecturer. Members of faculty, other members of academic staff, our specially invited guests, members of family of Professor Graham Sargent, students, colleagues, special guests, welcome. It really is a pleasure to bring greetings on what is in itself a distinguished occasion. Professor Wright Pascoe Williams made the point that having a distinguished lecture is a part of good university life. And I'm happy to see the Department of Medicine living that out. And in fact, it's very exciting, and it says a lot that as we bring a distinguished lecture to you in the faculty, we don't have to go outside, so to speak, to find a distinguished lecturer. That Professor Graham Sargent is one of our own. And it speaks to the fact that the university in 70 years, the faculty after 70 years, has a proud tradition of excellence. In fact, and Professor Sargent, we know him well for his work on sickle cell disease. And if you look at the history of the faculty, we're 70 years old, if you look at the history, a big part of that history of the faculty is sickle cell disease. If you write the book on the history of the faculty, you'll see that some of the earliest papers that were published were really on sickle cell disease. And the nice thing about it is that that history hasn't died. It's a living history. It has lived on. Professor Knight Madden, Professor Marvin Reed, Professor Sue Walker and team have continued to fly that flag. And a living history that is growing and making an impact. So the whole lifespan and the impact of the interventions on sickle cell disease, we have seen really, really tremendous benefits over the years. I know Prof. Sargent will say a lot about that. But I'm very proud for this particular moment for us this evening to have this opportunity to celebrate excellence, to really celebrate the excellence of the work of Prof. Sargent and his team, and to continue to celebrate the excellence of the faculty. You heard from Prof. Wright Pascoe Williams that in our recent MBBS exam results, we are very pleased to see, she mentioned some figures a while ago, but in addition, our Mona campus got the top medal, top clinical performance in surgery, top clinical performance in ONG, and so we have our top students, our students are performing very well. But across the board, I was very proud with the overall pass rates and the performance. So again, let me especially thank our clinicians, our members of medicine, our other departments who are here, the Department of Medicine, for their work. Thanks. So as we celebrate this evening, in this early period of my deanship, one of the things I wanted to commit to was a commitment to ensuring that the history of the faculty lives on. And as we talk of the great events, we know in 1948 when that class started, we know of the stalwarts who have contributed over the years and year after year. I'm happy to tell you that we are in a process of documenting that history. And I have a team working on it, and I expect in November of this year, and we are committed, we have a deadline, I've set a deadline for the team, that we'll be launching the Faculty Museum. This is, we have a space dedicated for it in this building, and it will include not only many of you who would know the old museum had a lot of the pots and the pathology specimen and so on. We'll have some of that in there, but we'll be really documenting the living history of the Faculty of Medical Sciences. And we expect to launch that during our annual Research Week conference in November. So look forward to that. That museum is going to grow from strength to strength and will document the work of the faculty. So let me just say thanks again. I want to congratulate the Department of Medicine, Prof. Wright Pascoe Williams, you and your team for continuing the legacy of excellence for the faculty, and by putting in this effort and this work here this evening to bring us together to hear, the wonderful life story of the work done on sickle cell disease as we look at the topic geography, the power of geography from Professor Sargent. Thank you very much. Welcome. Wish you a good evening.
Thank you very much, Dr. Paul, for those greetings. Our next phase is to get into the real meat of the matter, and the person who has been trusted with the introduction of our esteemed speaker is Dr. Swain Rogardner. Dr. Rogardner.
Good evening, everyone. I am very honored this evening to be asked to introduce our guest speaker, Professor Graham Sargent. Professor Sargent was born in Bristol, England in 1938. He did his medical training at London Hospital Medical School. After completing medical school, he did his internship at various hospitals in England. He got married to the lovely Beryl King in 1965, and over the years, she has been instrumental and very supportive in the work that he did. Together, they left England for Jamaica in 1966, where Professor Sargent was to take up a one-year contract in the Department of Medicine at the then University College of the Hospital of the West Indies. It was then headed by the late Professor Eric Cruickshank. During that year, he was introduced to sickle cell disease by Dr. Paul Milner, who was then the head of hematology. He was requested at that time to assist in expanding the Sickle-Cell Clinic. His interest in sickle cell disease developed and rapidly increased, which resulted in multiple research involving patients with the sickle cell disease. This partnership with Dr. Milner continued until 1971, when the Sargents returned to London, but they quickly returned to Jamaica in 1972, where he continued his work in sickle cell disease. His work continued with undertaking the Cohort study His work continued when he returned to Jamaica in 1972, when he undertook the Cohort study of sickle cell disease from birth. This Jamaican Cohort study has taught the world much about sickle cell disease and the development of cost-effective interventions appropriate to manage the disease with limited resources. Professor Sargent directed the now Sickle Cell Unit from 1974 until his retirement in 1999. Even after his retirement, he continued to work full-time as chairman of the Sickle Cell Trust and was still actively involved in research. He continued his research, which was funded by multiple agencies internationally and privately. He has published 480 scientific papers and 3 books, which many of us are familiar with and have used in our clinical practices. His work has been internationally recognized by the British government with an award of the Companion of the Most Distinguished Order of St. Michael and St. George in 1981, by the government of Congo-Brazzaville with the award of the Merit Congolese, and by the Jamaican government with the award of the Order of Distinction Commander Class in 1996, and the Order of Jamaica in 2015. So it's evident that Professor Sargent is more than qualified to speak to us today on the topic of sickle cell disease, geography, and time. Ladies and gentlemen, please help me welcome to the podium our most distinguished and influential guest speaker this evening, Professor Graham Sargent.
Somebody must be blind. There's a pair of glasses here. Oh. I've lost my mouse. Oh, there he is. All right.
I know everybody is waiting with bated breath for what Professor Sargent has to say, but I just need to make a quick announcement. Will the driver of car 3524 GC, well, that's the license plate. I have not been given the make or model of the car, but if you know your license plate and this is you, apparently you're blocking in somebody or you're parked somewhere that you're not supposed to be. So if it's you, please make the necessary correction. And on that note, I will welcome Prof. Sargent back. I apologize, Prof. I'm so sorry.
Thank you. Well, as you know, where's my drop? As you know, realize I'm going to be talking on sickle cell disease. And I thought what we would do was to review the gradual development of knowledge over the last 100 years using this format, which you will see repeatedly. Events in Jamaica, events in the US, and events elsewhere. Thank you, that's marvelous. And now I'm taking the risk of people going to sleep, but hopefully we can avoid that. All right, so where to start? Well, to start with the first case report, 1910. So the entire published history of sickle cell disease is just over 100 years. And that case report was published by Dr. James Herrick. He was a physician in Chicago. And between 1904 and 1907, he saw a patient with a combination of symptoms on a very unusual blood film. And that led in 1910 to the first description of sickle cell disease. As you can see, rather long-winded, peculiarly elongated and sickle-shaped red blood cells in a case of severe anemia. The interest to us in the Caribbean is that that patient was a dental student from the island of Grenada. We knew nothing else about that patient until Dr. Todd Savitt, East Carolina, took it upon himself to try and research who that patient was. And he went to Chicago and he managed to access Dr. James Herrick's working papers, and he found a blood film. A report here, which you can see, on the 31st of December, 1904. The patient had only arrived in America in September of that year. You can see the low hemoglobin, 50% in those days. You can see, lost my red dot, all right. Oh, I can't see it from here anyway. You can see the high white count, which is characteristic of the disease. And then bottom right, you can see the drawing of these very unusually shaped red cells. You also learn that the patient's name was Noel, Walter Clement Noel. And Todd then went down to Grenada and tried to research the history. He was in fact a successful dental practitioner in what is now the People's Pharmacy, just opposite the entrance to the hospital. Never married, but had a successful practice for 16 years before he finally died at the age of 32, following a day at the races, which some would say is a good way to go. He also found this patient, and sitting front left is a venerable lady who is 97 years old. At the age of 16, she developed toothache and went to see Walter Clement Noel. And she could recall him, she could describe him, and the point of that story is that the entire published history of the disease is almost within the life of a single individual. Dr. Savitt then went up to the Catholic cemetery at Sauterres in the north of Grenada to find the tombstone. And there it is, the biggest. I spent an afternoon, actually it was a morning, on my knees with the obligatory Irish priest, looking for Walter Clement Noel. And finally we found him there. He was the biggest tombstone in the entire graveyard, buried by the side of his father, a Gaelic cross to the right, John Cornelius Noel, who interestingly enough died at the age of only 37, so he only lived 5 years longer than his son with sickle cell disease. The Catholic Church then erected this huge concrete cross in 2002, and marked by the arrow is the headstone of Walter Clement Noel. And you can imagine what happened after Hurricane Ivan. The cross came down totally destroyed, the headstone. You see Mrs. Sargent standing there. The base is to her left. The body of the Coombs tombstone is behind her. And then the rugby ball at the top is to the right. So a rather sad ending in some ways. But in fact, the Grenadian Sickle Cell Association became very active, and they decided that they would restore this tomb because it was an important feature in the history of sickle cell disease, but also in the history of Grenada itself. So they created this family tomb. It doesn't have the authenticity of the original gravestone, but we're pleased that it's there. So that's 1910. The second case was 1911, the third case 1915. The fourth case was 1922, so it took 22 years to get the first 4 cases together. And here you see that paper, published in 1922, but considered of such importance that it was republished in 1985. And the author of that paper was Vern Mason. And it was Dr. Mason who actually reviewed those first 4 published cases, was the first to use the term sickle cell anemia, and also noted that all were of West African origin. And of course that was the beginning of this common misconception that the disease is confined to people of African origin. Vern Mason then moved from Johns Hopkins to Hollywood, where he became a physician to the stars, and to Howard Hughes, and he actually directed the Howard Hughes Medical Institute for some years. Not much had happened in Jamaica at that time, but in 1944 the Irving Committee met and recommended the formation of a university. And this is the first home of the University College of the West Indies, 1947, 62 Lady Musgrave Road, a building that is still there and used by the government. Let's move on now to 1949, to the genetics of the disease. There was a huge amount of confusion here. What you found was people who were sickle positive, and all they had was a positive sickle test. Some were sick and some were not sick. And so there was this concept of latent sickle cell disease and active sickle cell disease. And it was, in fact, 2 people working under totally different circumstances who sorted this out. One was Beat, who was a colonial medical officer in northern Rhodesia. And on the basis of this single, large, extended family, he was able to show that the sickle cell gene was always inherited from a parent. And in fact, if it was inherited from both parents, then they often had the disease. And in fact, in the same year, Jim Neal, a geneticist at Ann Arbor in Michigan, reached the same conclusions. He found 29 cases of sickle cell disease, could find 42 parents, tested them all, they were all sickle positive. And so this is hemoglobin electrophoresis. This is the technology that evolved, in fact, 5 years after these reports. But it makes the crucial distinction of people who are SS, who have S only, and people who have S and A, who are the sickle cell trait. The first are often sick, the latter are usually not sick. So now we understand what was going on with latent and active sickle cell disease. Furthermore, if both parents have the sickle cell trait, we also know that there is a 1 in 4 chance at each pregnancy that the child will inherit the sickle cell gene from both mother and father. And the corollary of that is that if one parent is absolutely normal, AA, they cannot have a child with sickle cell disease. And of course that will be the basis of the attempts to prevent the disease in the future. Just very briefly, 1 out of 4 sounds pretty good. If you're a betting man, you would say, well, that's not bad. There's a 3 out of 4 chance, even if both parents have the trait of having a child that does not have the disease. But you need to have very large numbers before that works out. And here is one particular family that we saw in the north of Maharashtra in India, where, reading from the left, the father was AS, the mother was AS, and then SS, 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 AS, SS, 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 AA. Two SSs are missing. Sadly, one had gone shopping on the day that we were there, and the other one, sadly, had died. Now, the genetics are very simple and straightforward. And if both parents have SS disease, there's only one sort of child that they will have. And nobody would recommend this, but on the left is Dennis, diagnosed at birth in the cohort study, cohort 92, and on the right is cohort 235 in the cohort study. We didn't know that they were living together until they had their first SS child. And then we tried to counsel, and they had another SS, Jodie Ann, and then another SS, Kai, and then another SS, Natalie, and then another SS, Imran, and then we actually managed to persuade her that it wasn't wise to go on filling the world with SS children. But I think the other side of this story is how well many people are with SS disease. And when you talk to them, they say, well, you know, you tell me I've got SS disease. Big deal. I don't seem to have many problems with it. And I think this is a recurring theme that you'll see during the presentation. The next development was the association of malaria with sickling. And this was very important because if you look very carefully, and here my red dot will desert, well, I might be able to do it with a red dot. You can see there and there, you can see malarial parasites in red cells. And what was realized early on was that people with the sickle cell trait ran lower parasite counts. Parasite counts are related to the severity of malaria, so they were less likely to get malaria, and it was less severe, and they were also less likely to die from malaria. So this means that they had an advantage during a critical period of early childhood when they were losing the maternal passive immunity until they developed their own immunity. That window was vitally important if you had the trait. You were more likely to survive, you were more likely to pass on your to have children and to pass on your genes. So the trait became more and more common in malarial areas. And that, of course, explains to a large extent the similarity in distribution in the African continent between the distribution of the sickle cell gene and that for malaria. Now we can come back to Jamaica. 1965, we've already heard about Dr. Paul Milner, and it was Dr. Milner who actually started the Sickle-Cell Clinic. It was held on Friday mornings in what was then known as the gynecology outpatients. This was a large clinic in those days, and those of you who work in the hospital may recognize this gentleman who is now a 62-year-old porter still working in the university hospital. That was far too cramped to do anything. Running a service that was only where you had facilities only half a day a week just couldn't work. And we were very fortunate with the Ripple building, which is built for medical research, not clinical research, but for research. And we were able to obtain room 3, which was a double unit there marked in pink. And here, if you look at the sign on the door, it says, clinic hours, weekday, 8:30 to 12, Saturdays, 8:30 to 10, only emergencies or appointments out of these hours. But the point is we could now offer a service for 5 days, well, 6 days of the week. And it was an extremely efficient organization. You can see the plan of the Ripple building, room 3 as it was known there. And in fact, the patient came in here. There was an internal waiting area. They then met beloved nurse Lena, who sadly died while she was still with us, having done superb work with us. They then had their height and weight measured. They had their records kept in a central desk there. They then moved over to the doctor's corner. And here you see Dr. Tony John, one of our pediatricians, showing a mother how to examine for the spleen. And this was part of a study where we looked at the 5 years before this education program and the 5 years after this education program. And we found that the apparent prevalence of this complication had more than doubled. These were events detected by the mother at home and confirmed by the doctor in the clinic. So the first message is you can teach your mothers to diagnose this, the complication of what we call acute splenic sequestration. This turned out to be one of the biggest causes of death in the first few years of life in the cohort. What happened to the death rate? It fell by 90%, simply by teaching the mothers about this complication and how to diagnose it. So after meeting the doctor, they then went down to the area, blood taking right here in the laboratory, and then sample analysis there. So we had a totally integrated service within one room, which some days was a little bit tight. 1969, we actually had the first international conference on sickle cell disease. And I don't know whether, can you see the arrow that I've got? You're seeing it, all right. This is Dr. John McKeever. Whoops, sorry, let me go back. Can I go back? How do I go back? No, I don't do that. Hang on. Oh, I have to find the keyboard. Perfect, thank you, okay. All right, won't do that again. This is John McKeever, and this is Lou Vent. And between them, John was a hematologist, Lou Vent was in chemical pathology. Between them, they laid the foundations of a lot of the laboratory work in sickle cell disease. At this meeting, there is here Dr. Lemuel Diggs, who is one of the grand old gentlemen of sickle cell disease, working out of Memphis, Tennessee. Here is Dr. Paul Milner, who was the hematologist who started that clinic. Over here is Professor John Waterlow, who of course started the TMRI. And then here is a gentleman who you've heard of quite a lot recently, Dr. George Elaine, who 50-something years later became, of course, Chancellor of the University of the West Indies. The challenge in those days was to try and work out why the disease seemed to be different in Jamaica. You read the textbooks, and this is what they said. Dreadful disease, everybody dies, people don't survive adolescence. And yet, people like Albertha, living in Augustown, would appear in the clinic at the age of 55 for the first time, and live until she died from chronic kidney problems at the age of 67. And so we evolved the hypothesis that, heaven forbid, maybe the textbooks were wrong. And when you thought back, you thought, well, textbooks written by doctors, doctors work in hospitals, clinics, doctors see only sick patients. Doctors don't get out into the community and actually see the other side of the disease. And I think that was one of the huge benefits that we had in Jamaica. We decentralized the sickle cell clinics. We still conducted the clinic in Kingston, but we started 6 peripheral sickle cell clinics, conducted every 6 weeks at 6 of the major hospitals. 1, 2, 3, 4, 5. St. Anne's Bay should be there, but isn't. And then we had a mobile clinical unit. And this would actually run slightly faster than most of our patients could run. And we would overhaul them in the countryside. This is actually Red Bank and St. Elizabeth. And one of the studies we did was 50 patients who now would be over 30 and hadn't been seen for 10 years. The obvious inference was that they died. You've got a severe genetic disease. They don't come to the clinic. Obviously, you're no longer around. The conversation went a little bit like this. Why did you miss your appointment 10 years ago? Doc, I was going to come tomorrow. Or they say, Doc, as I've got older, I've got better. My bone pain crises no longer occur, my leg ulcers have healed, I'm having a better quality of life now than ever before. And that was a total surprise. And what was interesting, the difficulty we had in publishing that paper, because it was 60 patients over the age of 30 years, relatively benign sickle cell anemia in the West Indies. And the editor said, they're talking about the trait. We know nobody survives to the age of 30. And we weren't. And I think that just shows the impact of bias in medical observations. And the corollary of that is, in fact, when we had 102 patients over the age of 60, we also had a difficulty in getting it published. These are all SS disease. Because they said everybody knows you survive to 60, so, this is no big deal. So attitudes have changed enormously. And we thought we were doing a good job, actually, reducing this. Rosemary, Who's Jeff? What time do you want me to finish? All right, so we thought we were doing a good job until this day, Seven Rivers in St. James. And here was two ladies, and Violet on the right had a severe form of sickle cell disease. And she was being followed regularly in the clinic, and we used to see her regularly. And then running around the yard was Myrtlin, the lady on the left. And she was 2 years younger. She's already the same height as Violet. She has a different body build. She has a different affect. You say, well, this illustrates the effect of sickle cell disease on growth and body build, everything. Just not to be caught out, we did a blood test in Myrtlin, and Myrtlin had exactly the same condition. So the end result was we'd reduced the bias, but that bias was still there. And that was, of course, the background to the Jubilee cohort study. This is clearly an old picture. The new Victoria Jubilee is being built behind. The old Victoria Jubilee had 2 delivery rooms over the left behind the palm tree. And each night, each of those delivery wards would produce a bed full of babies. And we screened 100,000 babies over 8.5 years. And you say, big deal, so what, this is routine stuff these days? Well, it is, but in those days, people said you can't diagnose the disease at birth. There's too much fetal hemoglobin, you can't do that. Jamaica did. And you can see the 4 principal genotypes of sickle cell disease here, and approximately 550 cases picked up. And then we had some normal control children born at the same time to compare them with. And this was the structure of the study, cohort 7, born in 73. The lady in the middle has a baby that we believe will develop SS disease, and she's flanked by 2 controls, babies of the same gender, born virtually at the same time, usually the one born immediately before and the one born immediately after. So that was the structure of the study. In fact, this is cohort 9, and here they are at 9 days. You can see, again, the mother with the child to develop SS disease in the middle, flanked by her AA controls. I've lost control. Where is the technical gentleman? It should carry on.
Should you go another one?
Yes? There's a whole... Ah, how did you do that?
Right arrow.
Oh, a different finger.
Yes.
All right, all right. Here they are at 9 years, in exactly the same positions. As you can see, the SS girl is growing just as well as her AA controls. The mothers are also growing, becoming pillars of the community. 15, we've lost the mothers. You can never get 3 mothers and 3 children together at the same time. Nicole in the middle was the first, it was still prepubertal. Susan on the left, 1 normal control, is postpubertal. Yvonne on the right is going into puberty. Here they are meeting a visitor to the unit when they were aged 20. Here they are aged 26. Nicole in the middle was the first to have a baby with sickle cell disease, first to have a baby, and she had sickle cell disease herself, and then flanked by her 2 AA controls. Here they are at the age of 32. Here they are at the age of 40, and in fact next month they're going to be 45, so we'll have another picture to take it out, but exactly the same positions. And the point I'm making here is, you know, there are few, if any, countries in the world where you could conduct this sort of long-term follow-up. All right, let's move across now to the US, and here they're doing they've started also to do a clinical study on sickle cell disease. It was 5 years after Jamaica, but as you can see, much larger numbers, complicated by getting patients from 23 different centers. Data collection finished initially after 10 years. Small subgroups were continued. Data finished after 20 years. Again, in Jamaica, at the age of 45, our patients still call us up to see how we are. Let's now move on to 1984. One of the major problems that we encountered, we've already talked about acute splenic sequestration, and here we're now trying to prevent overwhelming blood infections from the pneumococcus. The spleen is damaged very early in life in SS disease, and the spleen is an important filter taking out damaged red cells and bacteria that get into the blood. In SS disease, there are so many damaged red cells, that spleen is shot, usually in the first year of life. So these patients are prone to overwhelming blood infections, giving you brain damage and death. And you can see, if I dare move this thing, yes, there we are. You can see these black arrows are the events of pneumococcal septicemia. Starting at 6 months, 5 in the first year of life, 3 in the second year, 1 in the third, and 1 right down here at 5.5 years. So it looks as though the major problem was between 6 months and 3 years. And so what we did was we did a trial to see whether we could actually prevent this. This is Nurse Helen Jackson, who did this on a domiciliary basis. The injections of penicillin are painful, but transiently painful. And it was very difficult giving them in the clinic when you got an injection, but you couldn't examine the child again. Whereas at home, they never actually connected Helen with the sickle cell unit. So that worked very well. Helen did a superb job. Those of you who were around in the 70s will know something of the problems facing people trying to do domiciliary visiting in the late 70s. And it was published, The Prevention of Pneumococcal Infection in Children with Homozygous Sickle Cell Disease. We then move on to bone marrow transplantation. And this is 1984. And it was a paper written in a young lady who had acute leukemia and also SS disease. She lived in Alabama. She was at hospital in Birmingham, and in those days Birmingham didn't actually do bone marrow transplantation, so they shipped her up to St. Jude's in Memphis, where she had the procedure done, and they shipped her back to Birmingham for the follow-up. So I decided I would try and locate this lady and see if we could bring her down to Jamaica. It was quite an interesting exercise because most of the authors had moved on from where they were working, but I did manage to find one of the authors, and he gave me her name. Her name was Kimberlyn Wilson. And then I managed to get to the records department in St. Jude's and also in Birmingham, Alabama, and get her address. And after repeated phone messages, not getting anywhere, I finally woke her up on a Saturday morning at about 10 o'clock and explained who I was and what I was doing, and she jumped at the opportunity to come down. So this was for one of the university lecture series towards the year 2000. And there is Kimberlyn on the left, who actually had some years earlier been cured of both sickle cell disease and of acute leukemia. On the right is a lady, Etta Forrest, who was one of our 70-year-olds, just to illustrate the other aspect of the disease. Now I'm really in trouble. Why does it not click normally? You're not sure? Carry on, go forward. Oh, your finger's no good either. Yeah, next. Ah, good, thank you. So I keep on this one. All right, fine, thank you. And here is Kimberlyn enjoying lobster at Port Royal. So this one here, right, okay. All right, now we're going to move over to elsewhere, to haplotypes. This is DNA has progressed. This is now 1985. And Dominique Leby from France is actually working at the Institut Pasteur in a number of different French territories, and she finds there are differences in DNA structure surrounding the hemoglobin S mutation. And the most rational explanation for this is that there have been several independent mutations causing the hemoglobin S molecule. And so they're named after the areas where they were first described. Benin, most of the Jamaicans are 60% homozygous Benin, 80% heterozygous. So most of the patients in Jamaica, in the Caribbean, and in North America are the Benin haplotype. Brazil, interestingly enough, has equal numbers of Benin and Bantu. Bantu is the only one seen in East Africa and in Central Central Africa. So there's 3 African forms, and hello.
No.
No. You're very welcome. So here we are. Now we're in the Arabian Gulf and central India. And here there is a 4th independent occurrence of the hemoglobin S mutation. Yes, got it. All right, and believe it or not, it started in Leukovia, or should I say the first data were collected from Leukovia. And here you see where Leukovia is. All of you will know that, of course. And here's an extended family. Now, the ones who are completely black are SS disease, and so there's 6 in one family, there's 2 in another family, and there's 2 cousins to the left. The fathers were brothers, and their mother, Lucky Sohan, was pure Indian. And we realized in those days that this was a different haplotype. And the interesting thing here is they had high levels of fetal hemoglobin, which meant that they were actually mildly affected. So here's the family at home in Leukovia, and here's Mrs. Sargent taking a blood from Cordell, one of the oldest patients in that group. So we found it here, and then, of course, when we went to work in India, we found it was the only haplotype that you see in India. It had been preceded by work in 1952, when Herman Lehman started to screen tribal populations in the south and find aboriginal communities. The modern term for this is tribal, and then the non-tribal. And you can see that the tribal people had it, and the non-tribal people didn't have it. But that, again, is another misconception, because across central India, vast numbers of people with the scheduled castes have it. And looking at the tribal people in southern India, in the north of Tamil Nadu, a Toda, member of the Toda tribe, a lady of the Paniyan tribe. And I said, how old is she? Through an interpreter, and they said, 23. So I smiled. I know people in Jamaica who've been 23 for years. So I said, how do you know she's 23? And they said, actually, Doc, she was abandoned as a baby in this hospital 23 years ago. And she was actually raised by the nurses and doctors. So they were right. And to give you an idea of her size, you can see her here beside Beryl, who measures 5'2". And when we went back in 2007, we showed them this picture, and they said, oh, that's Narayani. Yeah, she died, but only shortly before we were there, and she reached the age of 42 years. So even in that community, with all the potential disadvantages of malaria, malnutrition, and everything else, people were beginning to survive. 1986, the Sickle-Cell Trust was formed. And this was a registered charity that raised funds to actually supplement the core funding that we got from the Medical Research Council. This was their first project, diagnostic ultrasound machine, and we used it for detecting gallstones. In sickle cell disease, you destroy your blood very rapidly. Normal red cells of normal people last 120 days. In SS disease, they last 10 to 12 days. So you're destroying your blood 10 times faster than normal. This means that you're generating a lot of bilirubin, you concentrate it in the gallbladder, and you end up with gallstones. Looking for my arrow. All right. So enter the cohort. So we said, okay, we've got the machine. Now we want to find out how common gallstones are and what they do. And we said, well, no one's going to have gallstones before the age of 5, so let's start at the age of 5. And at the age of 5, 7% already had gallstones. And you can see this steadily increasing prevalence, so that by the age of 25, 50% of those patients have gallstones, which means that if you see any SS patient at the age of 25, there's going to be a 1 in 2 chance that they have gallstones, even though it's nothing to do with the problem they came to see you with. Then we leap ahead to 1988, the Sickle-Cell Clinic. We'd long outgrown the Ripple building, and we were fortunate with the Sickle Cell Trust to raise funds to build on the other side of the MRC laboratories on campus. And there's the building taking shape with the roof. There's the final building, which was opened in August '88, just in time to greet Hurricane Gilbert. And let's look quickly at this. This is the outpatient, the external waiting area, the reception area, inside waiting area with videos, educational videos about sickle cell disease. And there's Jennifer Knight, who currently, of course, as Knight Madden, directs the sickle cell unit, but she is working in one of the 4 consulting rooms. So we're now in a far better situation than we were in the Ripple building. And there's the integrated laboratory, which is all part of the building. And here is the treatment center run in those days by a Ugandan lady called Irene Ochaye. And so we offered a holistic program for our patients. And one of the major developments of this was the day care center. And one of the major problems in sickle cell disease, as you will know, is severe bone pain. And what used to happen before was people would come in with a painful crisis, they would languish in the corridors of accident and emergency, casualty, often lying on stretchers, waiting for a bed to become available. Now they could come into the daycare center, they were assessed, they were given pain relief, they were given fluids, and they were asked at the end of the day whether they wished to go home with the same pain-relieving medicine in tablet form. 92% of them chose to go home. They knew they could come back the following day, but these are people who previously would have all been languishing in accident and emergency. But we soon outstripped our 4-bed daycare center, and here you see the extension into the waiting areas of the corridor. So we had to get the builders in again to knock a hole in the wall into the next consulting room. So we then had an 8-bed daycare center, which I believe is still outstripped with the approximately 5,500 patients under regular review in the study. The other point I want to make is this. This is the door of the Sickle-Cell Clinic. And patients say, we've only got to reach the door of the Sickle-Cell Clinic to start to feel better. What has that done? No injections, no morphia, nothing, just reassurance. And I think that's a vitally important lesson, again, from the work in Jamaica. My finger seems to have lost its... Oh no, I'm pressing the wrong one. All right. So, of course, this clinic was actually nearly half a mile from the original clinic. So we had a patient minibus which was donated by the Dutch government, and Alcan Sprostons actually donated perhaps the only sickle cell clinic bus stop in the world. So we did our best to offer an integrated service. Another 6 years passed, and now we realized that we'd learned a huge amount about sickle cell disease, and that wasn't getting out to the people who most needed it. Busy doctors in Clarendon and St. Thomas, all around. And so we decided that we needed an education center. And I spent a lot of time generating a sort of sales pitch, with colored pictures. So it was a good investment. And these went to corporate wastebaskets all over Jamaica. And then finally, Maya Matalon, his secretary, told me this. Get that one about the sickle cell center out of the waste paper basket. We were looking for 5 million, and Maya, with the telecommunications of Jamaica in those days, gave us 7 million because they wanted to build it and also to equip it. So here is, you can see the clinic underneath, still continuing, of course. You can see the final complex with the education center on top, and just one of the off-campus nursing schools who came for the lectures. This center was run by Carleen Mason, who may be with us. I hope she is. She's been with us for many years. Hydroxyurea was the next major development. 1995, Sam Sharash published a large study suggesting that severely affected patients certainly derived benefit from this. And then the next one, oh, look at that, marvelous. The next one was actually the ability to prevent strokes, which was TCD, transcranial Doppler. And here you see a gentleman, this is an American picture, but this is a program that continues with the current sickle cell unit. The thing is, with Doppler, you can actually detect cerebral stenoses, narrowing of cerebral vessels, which are what predict a stroke later. So we know that with chronic transfusion, or perhaps even with hydroxyurea, which is the arm of the study they're doing here, you can actually prevent the first stroke. Vitally important. So let's talk about now prevention of the disease. And let's go. You already know how to do it. One parent has to be normal. In Bahrain, they offered voluntary premarital screening for 8 years, and the prevalence of SS births halved. The king was so impressed that he actually in 2004, made a decree that nobody in the Kingdom of Bahrain can get married without being screened for the sickle cell gene. And the families then get a report that says this marriage is fine or this marriage is not recommended. The families can still go ahead, but they have been warned that there is a risk of children with sickle cell disease. So that program will certainly reduce the prevalence. And then if you go across the King Fahd Causeway, 25 kilometers to the mainland of Saudi Arabia, you will find the Saudi premarital screening program, which started at exactly the same time. And if you look at the last line here, 2009, the Bahraini population is 600,000. Saudi Arabia, 25 million. Look at the number of marriage proposals, nearly 300,000 in that year. They're all screened. 1,171 incompatible certificates, and over half of those were cancelled. Now, that's not such a big deal. You know, these are arranged marriages. The man may never have met the woman. They may know of them, but they won't know them well. And it just means that they'll use a different son or a different daughter to try and sort things out. And here we are. This is just one of the centers. This is in Jeddah, the Hospital for Mother and Children. This is, as you can see at the top, it says the male premarital screening, gentlemen there, ladies are somewhere else, of course. And an astonishing program that shows what can be achieved with virtually unlimited resources. So premarital screening certainly reduces the prevalence of SS disease in Bahrain and in Saudi Arabia. But these have traditions of arranged marriage. Jamaica doesn't have that tradition. And so, to the Manchester project. And here, in collaboration with the Ministry of Health, we decided to offer screening to senior school children in 14 secondary schools in Manchester. You can see the distribution of the secondary schools there, 14 secondary schools, 2 in the north, 4 on the top, 3 in the middle, and 3 actually in Mandeville itself. All the students were given cards. This was a voluntary, totally voluntary program. We went into the schools. It was all arranged beforehand. We offered them free screening. And then, of course, we offered counseling to carriers. And then we had to set up births in the region. But let's stay with the counseling at the moment. They had to fill in little demographic forms, and you can see it there, top left. Very simple things, you know, name, most people know that. Gender, most people know that. Date of birth. Mother's name, father's name. The object of this was so that we could actually contact the student afterwards. So the first thing to do when we got to the school, this is May Day, 3 gentlemen in the foreground are actually filling in the forms on a wooden bench. The lady in the middle is filling in the form on the wall. The lady behind her is filling in the form on her back. But basically, it was a system that was embraced and worked extremely well in those schools. Here you see vignettes of 8 of the schools, 8 of the 14 schools. We would go in the morning with a well-organized school, Cohort, Manchester, possibly Bishop Gibson. We could actually do 200 to 250 children students in a morning. And then we'd go back to the lab. They were all sorted, allocated ID numbers, and run through electrophoresis and hematology. So that was the structure. This is our champion school. This is a porous high school, which actually achieved 100% compliance in the 5th form of 189 students. Remember, these schools, some of them are massive. Manchester High School had 550 students in their 5th form. And then here you go, you can see the uptake over the 6 years of this screening program. And the message here is that people really did want to know. It rose from 55% to 92% over those years. Obviously, the girls, as you would expect, were more likely to be screened. Some of the boys came in very reluctantly with a girl on each side and were sat down to have a blood test. But in the end, it worked very well. And these are the results of 16,000 plus students. The sickle cell trait occurred in nearly 10%. The 3.5% is hemoglobin C trait. The bottom line is that 15%, nearly 1 in 6 of these students actually were at risk of a baby with sickle cell disease. So we now had to set up newborn screening to see what happened to them. And we screened 5 hospitals in the south, 4 in the north, and then we added in private hospitals and Lionel Town and Chapelton. So in the end, we were screening approximately 15,000 births in 13 hospitals. The proof of the pudding. Did it work? Here we've taken 216 eligible pregnancies. By eligible, I mean we've had to take out twins. We've had to take out those babies that were born before they actually received counseling. But you can see we would have expected 5.5 babies, and we got 5. So you go back to the mothers and you say, "Mummy, what happened?" She said, "Doc, I know I had the trait. I knew I was at risk of a baby with sickle cell disease, and I said to my boyfriend, you should be checked." He said, "Me? Nothing wrong with me." And there was. Not wrong, but important information they didn't access, didn't have. So acknowledgements. I'm coming up to her 30-minute line. The overall research, Wellcome Trust, British Medical Research Council, the ultrasound instrument, Air Jamaica, National Commercial, the costs of the Sickle-Cell Clinic itself, Education Centre, the outreach program, Guinness Brewing, and then all the support of the Manchester project, including, of course, the ministry, but 30 million from the National Health Fund, which was a huge contribution. Our acknowledgements, obviously the collaborators, especially the departments of the University Hospital, but groups abroad who were very helpful in supporting our work. Our staff, and this is purposely out of focus, so people don't sort of say, "I'm not there." You might be there. But they were, over 50 years, you had quite a lot of staff. And acknowledgements, finally, are patients and their families. And this is St. Elizabeth, top left, and then Westmoreland, and then Clarendon. Bottom left is Garland's District, St. James, Glengough, and then Cooper's Hill, just behind Kingston here. And in the right, you may be able to see Mrs. Sargent disappearing down the hill, 50 years younger, as we were all 50 years younger. And finally, the island, which made it all possible. Thank you very much.
So thank you for that lecture, Prof. That was one of the most well-spoken lectures on the history of sickle cell, and really did take us through the geography of sickle cell, everything from Michigan to Alabama to Jamaica to Brazil to the west of Africa to the east of Africa, and also as far as Saudi Arabia and to India. Truly sticking to that title and showing us the difference in the genetics and the haplotypes of sickle cell. I do have one small question though. There was a picture of you, and the one that was out of focus, you had a plunger in your hand. I'm not I'm not sure what the relevance of the plunger was to sickle cell. Yes, yes. And as we all know, plungers are very useful in the treatment of sickle cell disease. But so I don't know if we have any specific questions for Prof. Before we move on to the other items in the program. There's also one other small notice. There's another vehicle, a red Subaru 9263HH. If this happens to be your vehicle, you are parked in an unauthorized zone. So if you are the owner of this car, please make the necessary correction. Thank you. So on that note, I would like to invite Dr. Lisa Herlock to make a presentation to Prof.
Good afternoon, everybody. Professor Sargent, on behalf of the Department of Medicine, I would like to thank you for that extraordinary talk on sickle cell disease. We have all been privileged to be here to listen to your expertise on sickle cell disease, and we'd like to thank you very much. This is a small token from us here at the department, and we hope that yourself and Mrs. Sargent will enjoy this painting.
Thank you, Lisa, for that presentation. And we definitely cannot call the evening complete without the vote of thanks. I'd like to invite Dr. Pete Robinson to do that, do the honors.
Good evening, everyone. It's good to see you all here. Prof. Sargent, thank you so much for, first of all, for coming to talk with us and remind us how important sickle cell disease is and how much work has really been done in our country on this disease that really has taken a toll on our population. And you have made a significant difference to our population of people living with sickle cell disease in Jamaica, and also internationally with the work that you've done, the books that you've written. There are too many things to mention, but thank you. It was an excellent presentation, and I'm sure that for those who have not seen some of your work, it was a good snapshot and viewpoint into what you have done and how it compares to what has been done in other countries. So thank you very much for that. I also want to thank our sponsors. We had a number of sponsors that helped make our event possible. In particular, LASCO, MSN, Janssen, and Ray & Nephew helped to make this event possible, and we're glad that you could all be here to share with us. Thank you also to the staff, the administrative staff of the department, who put in a lot of hard work to make this happen, and to the members of the organizing committee. They did a lot of work as well. And thank you all for coming, because it would not be worth it if we didn't have an audience to share this with. I'm sorry, I would like to invite Professor Wright Pascoe up for a special thank you.
I'd like to invite Dr. Lisa Herlock to come forward, please. Dr. Lisa Herlock is not aware of this portion of the program. This is not to take away from the excellent presentation that Professor Graham has done, but we wanted to do some in-Department of Medicine work. Come forward. The Department of Medicine has been a very lucky department. We have some very bright, beautiful, committed people in our department. Volunteerism is very, very a given in our department. You ask somebody to do something, they will do something. Now, Dr. Lisa Herlock has been in charge of providing gifts for our distinguished guest speakers over the years, and she has excellent taste, as you might have noticed. And we thought it was time that we gave her a gift. A round of applause, please, for all her work.
So it's good to see that Lisa gets awarded for all the years of hard work. She really has been that person, and her taste is definitely better than mine. But so on that note, that brings us to the end of our program. So I'd like to thank everybody for coming. I wish you all a good evening and a safe journey home. Thank you. Oh, and join us for refreshment outside, please. In the room across the corridor.